Yeah. Welcome back, guys. Now we'll talk about congenital umbilical hernia. Remember, whenever the pediatric patient or the mother is exposed to low levels of thyroid, that is when you will have to think of congenital umbilical hernia for USMLE. Patient with connective tissue disorders such as Ehlers-Danlos syndrome, and the most common syndrome is Beckwith-Wiedemann syndrome. You'll have to think of congenital umbilical hernia. In the question, the examiner can mention that pediatric patient usually has got hypotonia and is diagnosed with a Down syndrome, you will have to look for congenital umbilical hernia as an association. It usually occurs in normal newborns as well, but you must not treat any of the patients because they typically close spontaneously. Whenever there is a large umbilical hernia of more than 1.5 centimeters with associated underlying medical problems, you will have to consider treatment. But remember, the treatment is done at 5 years of age if the patient has got persistent hernia. Or sometimes the patient develop complications, then you will have to do umbilical, then you will have to do surgery for complications as well. Next, we talk about umbilical granulomas. Whenever there is a red color pedunculated mass at the region of umbilicus, you'll have to think of umbilical granuloma. The patient can be of any age. And I also want you to understand that the treatment is silver nitrate. But in the questions, it is usually the newborns that usually develop this red pedunculated mass. That is when you'll have to think of umbilical granulomas. Next, I talk about incisional hernia. Patient with history of surgery, patient with history of poor facial closure, patient with history of heavy smoking. That is when you will have to think of umbilical incisional hernia. Remember, the patient will be obese, the patient will be having history of smoking. That is when you will have to think of umbilical hernia. The clinical features usually there will be mass at the previous surgical site. That is how you will have to diagnose incisional hernia. I also want you to understand that it is the diagnosis that is important. It is the clinical examination that plays an important role in diagnosis of incisional hernia. Next, I talk about ischemic colitis. This is commonly asked in USMLE step 2. Remember, we discussed this in medicine. The first most important thing you will have to find in the question is patient has got history of hypotension. Whenever there is hypotension, there is decreased blood supply to the gut and patient presents with abdominal pain with bloody diarrhea after an episode of hypotension. That is how I diagnose ischemic colitis. Obviously, the patient will have inflammation of the colon, sufficient presence with fever, nausea, and there can also be increased WBC count. Whenever there is ischemic colitis, there will be splenic flexure that is involved and rectosigmoid junction that is usually involved. The diagnosis is basically by a CT scan we will have to do. In the CT scan, the examiner will mention you in the options that there is a edema and air in the colon, or there can be thickened bowel walls as well. But whenever you do a colonoscopy or an endoscopy, you will find that there is a pale mucosa because of the hypertension, and there can also be petechial bleeding. That is how you will have to diagnose ischemic colitis. The treatment for ischemic colitis is basically you'll have to do colon resection whenever there is extension of the colon ischemia that is happening. Whenever there is perforation, whenever there is complication, you will have to resect the colon. Remember, in ischemic colitis, it is the perforation and it is the necrosis that is commonly tested in USMLE step 2. Whenever the patient does not have any complications, it is the IV fluids and antibiotics that we usually do. Next, we talk about blunt abdominal trauma. We talked about blunt abdominal trauma in medicine, but I'll quickly recap all the important points that you will have to remember. Whenever there is blunt abdominal trauma, first most important question is the patient hemodynamically stable or not? If the patient is hemodynamically stable, has this patient got any signs of peritonitis? Yes, there are signs of peritonitis. You will have to go laparotomy. Whenever there are signs of peritonitis, the first most important management is laparotomy, even if the patient is stable or unstable. If the patient is stable, you can do a fast assessment. And if the patient has got fast assessment and has got an peritonitis, you can do laparotomy, please. Very important. That is what I want you to remember. So, blunt abdominal trauma with signs of peritonitis, please do laparotomy. Blunt abdominal trauma on fast examination, please do. On fast examination, there is collection or signs of peritonitis, you will have to do laparoscopy. Or if there is free fluid on fast, you will have to do laparotomy, please. Next, when we talk about the management of blunt abdominal trauma, it is either the laparotomy or it is either the stabilization of the patient that we need to do. Whenever you do, you consider management of laparotomy. First, most important thing, has this patient got any signs of peritonitis? Yes, the patient has got signs of peritonitis or free fluid. You'll have to go with the laparotomy. If the patient has got inconclusive features on fast examination, it is basically a diagnostic peritoneal lavage that you will need to do. On diagnostic peritoneal lavage, if it is positive, again you will have to do laparotomy. Very important. Next, I want to talk about splenic injury in blunt abdominal trauma. We talk this in medicine. Whenever there is splenic trauma, the patient presents with abdominal pain, the right-sided pain, and there will be hypotension. That is the most important thing. Whenever there is blunt abdominal trauma or whenever there is splenic injury, please do look for hypotension as the most important thing. And the diagnosis is basically by a CT scan. That is what I will have to remember. Next, we talk about penetrating abdominal trauma, easily asked and easily missed. I'll tell you, if the patient has got hemodynamic instability, if the patient has got peritonitis, if the patient has got peritoneal penetration, then you will have to do laparotomy. These are the three most common questions asked in USMLE. Patient hemodynamically unstable, patient has got peritonitis, patient has got signs of peritoneal penetration, then you will have to go for laparotomy, please. Next, I talk about splenic laceration. Whenever there is splenic laceration, it is the hypotension again that I will have to remember. Whenever there is hypotension, there will be tachycardia. So you will have to make sure that a CT scan is performed in patients with hemodynamic stability. In patients with hemodynamically unstable, it is the fast scan that you will have to do. Because in order to do a CT scan, the patient must be hemodynamically stable. That is why we do fast scan if the patient is unstable. Very important. Next, I want to talk about GI perforation in blunt abdominal trauma. Whenever there is GI perforation, I want you to understand that in blunt trauma, it is basically because of the cutoff of the mesenteric blood. Whenever there is loss of mesenteric blood supply to the gut, the patient develops necrosis and patient can have perforation. So, whenever there is perforation, you will have to think that the gut is affected, and the most common involved structure is jejunum, which is usually involved. Remember this. Stomach and colon, they are rarely involved, but it is the jejunum that is most commonly involved. Next, I talk about duodenal hematoma, my favorite topic for USMLE. Duodenal hematoma, usually the patients develop time. The patient needs some time for the duodenal hematoma to be accumulated in the duodenum. Whenever there is hematoma that is accumulated in the duodenum, patient presents with the gradually progressive symptoms after 48 hours after a blunt trauma. That is how you diagnose duodenal hematoma, please. Duodenal hematoma, in the question, it is usually the children, because children will have thin abdominal wall and patient can easily develop hematoma. And then you will have to think of duodenal hematoma if the patient has got progressive bowel obstruction symptoms after 48 hours. In order to diagnose a duodenal hematoma, it is the CT scan that you will have to do. In management, it is basically it resolves in 1 to 2 weeks, and make sure that you do a decompression by placing an NG tube. Next, I want to talk about duodenal tear. Most common location is it is the duodenum. The most common location for the tear is duodenum because it is basically anterior to the vertebral column. Whenever there is whenever the duodenum is present close to the bony injury, it will cause compression, and there can be easily seen that can be easily affected, that is the duodenal tear can be easily formed. It is basically because of the compression against the vertebra, and it is basically seen in the blunt abdominal trauma. Remember, whenever there is duodenal tear, there will be rapidly increase in the intraluminal pressure that can cause duodenal tear, please. Next, I want to talk about atraumatic splenic rupture. Whenever there is a splenomegaly, there can be atraumatic splenic rupture. Remember, patient with hematological malignancies are easily prone for atraumatic splenic rupture. Sometimes patient with CMV, sometimes patient with Epstein-Barr virus, where we avoid contact sports. Patient with splenic congestion, such as portal vein thrombosis, can develop atraumatic splenic rupture. Whenever there is rupture, there is the left upper quadrant pain, and there can also be hemodynamic instability. That is, the blood pressure will be less than systolic blood pressure will be less than 90, please. If you have a stable patient with splenic rupture, it is the embolization that you will have to do as a treatment. If the patient is unstable, you will have to remove the spleen. But remember, try to maintain the spleen. So, first correct the hemodynamic instability. Remember, in USMLE step 2, if the patient is hemodynamically unstable, please do go ahead with emergency splenectomy. When you do an emergency splenectomy, the post splenectomy management is important because patient will be at risk of bacterial infections with capsulated organisms after splenectomy. The most common organisms are Streptococcus pneumonia, commonly tested in USMLE is Haemophilus influenza and Neisseria meningitidis. The first most important choice of antibiotics we will need to start is amoxicillin and amoxiclavulanate, please. If the patient is allergic to penicillin, it is the levofloxacin that we will have to start. Remember, for post splenectomy, the patient will also have to undergo vaccination. Vaccinations are usually administered after 2 weeks when the patient has got urgent splenectomy. The vaccination schedule or the vaccinations that we need to follow is a 13 and 23 valent pneumococcal vaccine, the Haemophilus influenza type B meningococcal vaccination, and seasonal influenza or annual influenza vaccines that we need to follow. Very important. Next, we talk about management of variceal bleed. Whenever there is management of variceal bleed, I want you to make sure that the patient has got two IV cannulas, that is large bore IV cannulas. Start with IV fluids, next go with IV octreotide, then only you will have to give antibiotics, please. If you do an urgent endoscopy and on the endoscopy you find there is no bleeding, you do not do anything. Please give him beta blockers and do an endoscopic band ligation within 1 to 2 weeks. But if there is continuous bleeding, you will have to do balloon tamponade. If there is early bleeding and if you repeat the endoscopy, if the patient has got recurrent hemorrhage, you please do a shunt surgery or you place a tips. Very important, please. I'll repeat this again. Whenever you find variceal bleeding, it is the large bore IV cannulas that you will have to do. It is the volume resuscitation that you will have to do. It is the IV octreotide and antibiotics that you will have to do. So you are stabilizing this patient, and then you will have to do endoscopy, ring your gastroenterology registrar on call, perform an urgent endoscopy. If on endoscopy, if the bleeding is stopped, you'll have to give beta blockers. If there is continuous bleeding, it is the balloon tamponade that we usually give. On repeat endoscopy, if the patient has got recurrent hemorrhage, if the patient will have to go with the tips, please. Next, we talk about Mallory Weiss tear. Whenever there is Mallory waste here, I want you to understand that the patient is a young patient, binge alcohol, sudden vomiting, recurrent vomiting, and the patient developing chest pain and epigastric pain. Remember, it is not completely tearing the esophagus, so that esophagus is intact. So most of the treatment usually is aimed at symptomatic treatment because most of them heal spontaneously. If there is vomiting, if there is hematemesis, you'll have to do an endoscopic therapy. Next, I want to talk about Borihave syndrome. Whenever there is forceful retching or whenever there is transmural tear involving the muscle, that is called as Borihave syndrome. The air escapes and there will be formation of crepitus, which is associated with chest pain as well. Whenever the patient swallows because of the tear, the patient will develop pain that is called odynophagia. Remember, the patient will also have esophageal tear or esophageal perforation. So, the ultimate diagnosis which can confirm the Borhave syndrome or Borhave tear is a esophagography or a water soluble contrast CT scan, please. Very important. And then for the management of Borhaves, it is basically you must not give anything to the patient. That is, nil per oral must be given, and then emergency surgical consultation must be done, please. Next, we talk about hiatus hernia. Whenever there is hiatus hernia, please do remember that there is a retrocardiac shadow. That is how you will have to diagnose hiatal hernia. The most commonly asked question is sliding hiatal hernia. Whenever there is sliding hiatal hernia, please do remember that there is gastric cardiac and there can also be the gastroesophageal sphincter that is above the diaphragm. That is how you will have to diagnose sliding hernia. Remember, whenever there is the gastroesophageal sphincter that is above the diaphragm, the patient usually develops retching. So the complication will be GERD. Whenever you find sliding hiatal hernia, it is the retrocardiac opacity or the retrocardiac air fluid level that you will have to treat. Whenever the patient is asymptomatic, you will have to do observation. Whenever the patient is symptomatic, first thing is you will have to give PPIs. Next, you can do Nissen fundoplication, please, if the patient has got symptomatic GERD. Whenever we talk about paraesophageal hernia, it is the gastroesophageal sphincter that is inside the diaphragm, whereas there will be herniated gastric fundus that is usually seen above the diaphragm. Remember that, very important. The complications are usually, the presentation is usually nausea and vomiting, and postprandial fullness will be present. Whenever there is complication as it is the aspiration or there can be respiratory compromise that can be present. Remember, the most important complication for paraesophageal hernia is gastric volvulus. That is how you will have to think of paraesophageal hernia complication in the question. The first most important diagnosis is chest X-ray, where you find a retrocardiac air fluid level behind the heart. That is what you'll have to think of about hernia. Next, we talk about a barium swallow, which can confirm the diagnosis, but upper endoscopy, upper gastrointestinal tract endoscopy is usually confirmatory. But and the answers in the options, there will be barium swallow that is usually given. Paraesophageal hernia, you will have to treat the patient if the patient is symptomatic, please, with surgical repair. Next, we talk about Zenker's diverticulum. One thing I want you to remember for Zenker's diverticulum is patients with Zenker's diverticulum on endoscopy, we will easily miss Zenker's diverticulum. So you please do a barium esophagogram for for Zenker's diverticulum. Usually in the question, the patient will be more than 60 years of age, presenting with hydatosis and presenting with dysphagia, hoarseness, or compressive symptoms. That is when you will have to think of Zenker's diverticulum. Remember, the management is basically a cricopharyngeal myotomy, or you can also do a open surgery or endoscopic surgery, please. Next, we talk about Esophagitis. First most important thing is esophageal esophagitis or eosinophilic esophagitis is what I'll think of. Patient presenting with background history of hypersensitivity reactions, asthma. There will be trachealization of the esophagus, that is, tracheal indentations are seen on the esophagus. There can be obstruction to solid food, that is when I will think of eosinophilic esophagitis, please. Biopsy is confirmatory, where you will find eosinophils. The treatment is dietary modifications must be done for this patient. Very important. The diagnosis is usually by the endoscopy or esophageal biopsy, where we usually do. That is, we'll have to do an endoscopy and then take a esophageal biopsy. On biopsy, you will find eosinophils, that is, more than 15 eosinophils can be seen. Next, we talk about dysphagia. Dysphagia, first most important thing, oropharyngeal dysphagia and esophageal dysphagia. Whenever there is oropharyngeal dysphagia, the patient will complain of difficulty initiating the swallow. But whenever there is esophageal dysphagia, it is the sensation of the food that is stuck in the esophagus. Remember, esophageal dysphagia can be because of motility disorder, or can be because of achalasia, or can be because of esophageal spasm. Whenever there is dysphagia both to solids and liquids, I want you to think of motility disorder. Whenever there is intermittent symptoms that are developing against solids and liquids, it is the esophageal spasm that we will have to think of. Progressive symptoms, if it is present, it is achalasia that we will have to think of. Remember, if the patient has got dysphagia only to solid food, it is because of the mechanical obstruction. Think if the patient has got progressive symptoms, it is because of the stricture or can be underlying cancer. If the patient has got intermittent symptoms, it is the eosinophilic esophagitis that I will think of. But eosinophilic esophagitis is the dysphagia is more common to solids than liquids. Next, I talk about esophageal cancer, middle-aged patient, difficulty swallowing, history of smoking, progressively worsening dysphagia to solid foods associated with the weight loss is esophageal cancer. The diagnosis is esophagoscopy with biopsy must be done. And next step is CT scan in order to make sure the extent of the disease. This is very important. Next, we talk about scurvy. This is basically because of a vitamin C deficiency. We discussed this in medicine as well. Whenever there is vitamin C deficiency, there can be hemolytic anemia as well. So the treatment for this is vitamin C. Remember, in the question, you will find petechiae, you will find follicular hemorrhage, that is hemorrhage around the hair follicles. There will be gingival bleeding and there can be impaired wound healing as well. This is what I want you to remember in scurvy. Next, we talk about the post-operative abdominal wound healing. Whenever there is poor wound healing, think of smoking, think of obesity, think of chronic steroid use, think of immunocompromised, think of nutritional deficiency. If the patient has got a chest infection and has got recurrent cough, please do treat the chest infection first. Next, we talk about bronchopleural fistula. We talk this in pulmonology. Bronchopleural fistulas is usually seen in surgeries involving the lung. The most common is basically a lung resection, but in the question, they will mention that the patient had a chest trauma and there will be recurrent fistulas or recurrent effusion even after the chest tube drain. That is when you will have to think of bronchopleural fistulas. Next, we talk about splenic abscess. There will be fever with the left upper quadrant pain. Remember, whenever there is splenic abscess, it is usually not developed in immunocompetent patients. It is basically developing in immunocompromised patients. There will be immunosuppressive agents. There will be chronic steroid use. There will be mycophenolate meftil. There will be organ transplantation history. There will be HIV, hematological malignancies, and there will be diabetes mellitus as well. Remember, in splenic abscess, the labs play an important role where you will find leukocytosis, and on the X-ray, you will find elevated left hemidiaphragm. Sometimes, if the splenic abscess is very big, you will find left pleural effusion as well. In order to find out the extent of splenic abscess, it is the CT scan that we will have to do. But in order to call it as a splenic abscess, you will have to think of CT scan to find out the extent of the splenic abscess. Whenever there is splenic abscess, antibiotic therapy is the first thing. If the patients are not responding to antibiotic therapy, it is the splenectomy that we will have to do. Next, we'll talk about evaluation of blunt genitourinary trauma. Whenever there is a blunt genitourinary trauma, first most important thing is urine analysis. Is there a hematuria? If the patient is hemodynamically stable and if the patient has got hematuria, you will have to do a contrast enhanced CT scan. Whenever you do a contrast enhanced CT scan, you are usually looking at the abdomen and also you are assessing the renal trauma. If the patient is hemodynamically unstable, the patient must undergo IV pylography, please. In the examination, the blunt genitourinary trauma, the patient will be hemodynamically unstable. It is the IV pylograph that you will have to do, please. Whenever you think that the patient has got urethral injury or bladder rupture, you will have to do a retrograde cystourethrogram, please. Next, we talk about trace mineral defects. When we talk about the trace mineral defects, we already talked about in medicine, but I'll give you an outline of what the examiner is interested in. First, most important thing is zinc. Whenever zinc deficiency happens, it is the hair fall, it is the skin rash that is usually fine. But if the patient is a male patient, hypogonadism is the most common finding in the question you will think of. The patient presents with impaired wound healing. This is what I want you to remember for zinc deficiency. Whenever there is selenium deficiency, patient develops cardiomyopathy, patient develops thyroid dysfunction as well. Whenever there is selenium deficiency, it is the Kashan syndrome that patient usually develop. If the patient has got a copper deficiency, the patient will develop a depigmentation of the skin and patient will develop ataxia and peripheral neuropathy with sideroblastic anemia. Whenever there is a chromium deficiency, it is the uncontrolled diabetes mellitus that we usually see in chromium deficiency, please. Next, I want to talk about bariatric surgery. Whenever there is bariatric surgery question, please do think of BMI more than 30 and BMI of more than 25 to 29 with the complications. First, most important thing is weight loss medications that can be asked in medicine. Orlistat is what I want you to remember, please. Orlistat is one medication where we can use anti-diabetic medication, which can be used in bariatrics, is liraglutide. Whenever the patient has got a bariatric surgery and now the patient has got complications, how do you identify it? It is the tachycardia in the patient that is usually suggestive of complications in bariatric surgery. Next, I want to talk about the post-bariatric surgical anastomotic leak that can be asked in a question, which is the most common complication. This usually develops in first week, but remember, there can also be tachycardia, there can be fever, and there can be abdominal pain. Remember, if there is tachycardia of more than 120, I want you to understand that this patient has got an anastomotic leak. Next, we talk about early nutritional support. We talked about the nutrition support in burns patient. It is basically the oral route that we have to make sure that the enteral nutrition is maintained. It is basically by a nasogastric tube or an orogastric tube. That is what I want you to remember. Next, we talk about cellular rejection of liver transplant. Remember, liver transplant rejection can happen within first 3 months of life or 3 months of transplant. There will be liver function abnormalities that is usually seen. This 3 months, what happens is there will be cellular changes that can be suggestive of liver transplant or cellular rejection. Whenever there is liver biopsy, that can develop inflammatory infiltrates that can develop biliary destruction as well. Treatment is basically immunosuppression, and you will have to do high dose corticosteroids you will have to use. If the patient has already been on IV corticosteroids or high dose corticosteroids, please use other immunosuppressants and use thymoglobulin or sirolimus as one of the most important immunosuppressant therapy we can use. This is the last topic in gastrointestinal surgery. Thank you very much for attending. I'll see you in the next video. Thank you very much.